So we're going to be talking about lung compliance and airway resistance. If you haven't looked through this PowerPoint already, I think it might be a little bit easier to go through it without the recording first so that you can kind of jot down the definitions and just get familiar with the terminology before you have to listen to me talk. So the first place we're going to start is talking about dynamic compliance. So in the previous lecture, we talked about compliance being the stretch of the lung. So when you think about it, as the lung inflates or air goes into your lungs, it has a certain amount of stretch. And we define that by calling that compliance. Specifically for this one, when you're talking about dynamic compliance, you're just talking about movement. So it's referring to air movement. That's all. So dynamic is movement, and in this case, air movement. So the first thing under dynamic compliance that we're going to kind of link together is something called a peak pressure. We abbreviate that with PIP or peak inspiratory pressure, also known as PIP. And what your PIP is the total pressure that is needed for a volume of gas going into your lungs to overcome the elastance of the lung, the surface tension of the alveoli, and the resistance of the chest wall. All of those combined are your elastic forces, which we previously talked about. The other thing that it's trying to overcome to inflate your lungs is your airway resistance and your tissue movement, which are your frictional forces. So you can kind of think back to the previous PowerPoint where we talk about the forces that oppose lung inflation. The two major categories that we discussed are elastic forces and frictional forces. Within each one of those subcategories, you have for elastic forces, you have the elastance of the lung, which is just talking about elastance equals recoil. And kind of the way that you can think about that is if you're stretching a rubber band, and as you stretch it, it's going to want to kind of shrink back down to its original position. That's all I'm talking about when I'm talking about the elastance of the lung. When you open up your lung and you inflate it, it's going to essentially want to go back down into its resting position. It has a certain level of recoil to it. The other thing that opposes lung inflation is surface tension, and we explain that by talking about how there is molecules, water molecules in your lungs that want to bind together. They want to get as close to each other as possible, and when they do that, they kind of pull that alveolar sac inwards with them. And the body's way of compensating for that is to make that surfactant. You have those type 2 pneumocytes that make that surfactant, that break up that surface tension, they break up those intermolecular bonds, and they allow those alveoli to open more easily. So that's the other force that opposes lung inflation. And then the last one, the chest wall, you can kind of think about the limitation of the skeletal system, people who have varying weight on their abdomen or on their chest. All of those things kind of resist the inflation of the lung, and those are all under that kind of larger heading of elastic forces. The frictional forces are your airway resistance, so just thinking about your airways and how the air moves through those and some of the things that can disrupt that, mucus or bronchospasm or things like that. Even if your airways are completely normal, there's a certain level of resistance that happens with them. And then tissue movement. Tissue movement is a smaller portion of that, but we did talk about how you have like your parietal pleura and your visceral pleura that surround your lung, and how there's kind of a fluid that surrounds them, and a fluid in the intrapleural space that tries to keep things lubricated, because as your lungs are opening and going back down to their original position, there's a level of friction that happens with that movement that you want to keep at a minimum so that you're not having to use a lot of pressure to open the lungs. So your peak inspiratory pressure, or your PIP, is the total pressure needed for the gas to go in and overcome the elastic forces and the frictional forces. So it's the portion of the breath when you Breathe in, okay, as you're pulling that air in. So the definition kind of at the bottom that's highlighted is the most succinct way that you can throw it on a flashcard. Your peak pressure is the pressure that is needed to overcome all elastic and frictional forces to open or inflate your lung. A visual for peak pressure that I personally find helpful is this. It's a pressure time curve, and the reason they call it that is on the y-axis here you have pressure. On the x-axis, you have time. So if you're looking at them in relation to each other, it's basically just showing kind of the entire ventilation cycle here. And the part that I want to draw your attention to is this line right here. This is your peak pressure or your PIP. Okay, and you can tell it's a sharp vertical line up. And that's because pressure is building, 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 building. And then this is where your lung would essentially inflate or open. And this is your peak inspiratory pressure. And again, it's just the amount of pressure that's needed to overcome both your elastic and frictional forces to open the lung. We'll talk about kind of the other parts of this curve as we keep defining different terms. The next thing we're going to talk about is static compliance. So we talked about dynamic compliance being about air movement, so dynamic involving moving of the air. Static is when everything is at a standstill, so essentially like a breath hold. Compliance is still defined the same way. It's the stretch or opening of your lungs, so the stretchiness of your lungs. So the static versus the dynamic, when you are talking about a breath hold, this is the pressure kind of in that in between your inhalation and your exhalation. So if you can imagine slowly taking a breath in as you're pulling that air in and you're feeling your lungs inflate, right at the top of that breath, when your lungs are as full as they can be, right before you exhale, that brief moment where there's no air movement, that is your static compliance. Okay, that air is not moving anymore. It's right before you're going to exhale. We refer to that pressure as the plateau pressure. Okay, and how that's different from the peak inspiratory pressure is that air is not moving. So the only pressure, the only thing that your plateau pressure has to overcome is the elastic forces. It does not have to take into consideration your airway resistance or the friction created by tissue movement. It's only dealing with the recoil of the lung, the surface tension of the lung, the elastic forces of the lungs, because that air is not moving, it's holding still. So that's what makes it different. Your plateau pressure is something that gives us a really good kind of insight into your lung injury or your lung health. So as you move through and you learn about the different diseases and you learn more about mechanical ventilation and different ways that we treat patients, we start doing a lot more with plateau pressure, because the pressure that you get in this kind of like static compliance and this breath hold is going to be the same pressure that's in your alveoli. And the reason that we know that is because it's only using, it's only overcoming the elastic forces. No air is moving, so as your lung wants to kind of recoil back down right before exhalation, it's showing how much pressure it takes to keep it inflated. And I feel like this is one where the more you learn through the program of like different disease states like fluid and lung injury and ARDS, acute respiratory distress syndrome, you start to understand why we care so much about these pressures. But for right now, we're just kind of building that foundation. So looking back at that same pressure time curve, okay, so you have that sharp inhalation right here where you're breathing in. This is your peak inspiratory pressure up here at the top. And then right before you exhale, kind of that breath hold, this right here is your plateau pressure. And you can see it's this horizontal plateau, no air movement. The difference between them is just, it's called delta pressure, or it's just essentially the change in pressure. And that's just kind of this one being up here versus this one being down here. There's a difference between them. But your plateau pressure is generally speaking lower than your peak inspiratory pressure, because this is having to overcome both your elastic and frictional forces, whereas this is your plateau pressure is only having to overcome your elastic forces, so generally lower. Another way to look at this, and although it's a simple analogy, it's for me very, very effective in kind of understanding what is going on in your lungs. Almost everybody has blown up a balloon, just a normal party balloon. And when you first start blowing up a balloon, it's really, really hard. That requires a ton of pressure to get volume of air in that balloon, right? So you end up having to apply a lot of pressure to get even just a little bit of air, or a little bit of stretch in that balloon. And then once you get some of that air in there, some volume of gas gets into that balloon and expands it, all of a sudden it gets much, much easier to continue to inflate it. And the same is true of your lungs. When you apply a large amount of pressure, which is your PIP, to start inflating your lungs, that's going to be kind of your higher pressure. Then once you get a volume of air in your lungs, you're at the top of that breath in, that pressure that is needed to keep it open is much, much less. This is kind of representative of your frictional and elastic forces and how much pressure it takes to overcome them. And then this is just when you're overcoming your elastic forces. And you could think about it as like the balloon wanting to shrink back down. When you think about the fact that that balloon is stretchy and it has a certain amount of elastins to it, it's going to want to return to its original shape. And it's the same kind of concept with your lungs. So a lot of pressure to get it started and get the air in, and then once there's air in there, a little bit less pressure. The next term that we're going to talk about is something called PEEP, positive end expiratory pressure. This is the pressure that's left in your alveoli after you exhale. So when you think about kind of your total breathing cycle, you take a breath in, you have this period of kind of a breath hold before you exhale, and then you exhale. When you exhale, not all of the air leaves your lungs, okay? So there's a volume of gas that's in your lungs all the time. This is called your reserve volume. I don't know if you guys talked about that in survey at all, but essentially it exerts a pressure in your lungs. So there's a certain volume of gas or pressure of gas that's always in your lungs, no matter how hard you try to exhale it out. And the reason that that happens, and we won't go into like all the different physiologic factors, but there's kind of a balance between your chest wall wanting to move out and your lung wanting to move in, and it creates this constant pressure or PEEP. And the reason that that's important is if you kind of circle back to thinking about surface tension, if you allow your lungs to completely collapse down after each exhalation, you don't have something in there to stent them open. Each time you go to take a new breath in, it's going to require significantly higher pressure to open your lungs. And that's not something that you want, because having to apply a lot of pressure to inflate your lungs can cause damage to those very sensitive tissues. Specifically, they call it barotrauma, or it's like a pressure trauma. So you have this physiologic PEEP, or this volume of gas that is constantly in your lungs. No matter how much you blow out on exhalation, it's still going to be in there. And that exerts a pressure. It stents open those alveoli. It stents open your lungs. In the same way that leaving a little bit of air in a balloon makes it much, much easier to blow up. It requires a lot less pressure to inflate. Same concept. That is essentially what PEEP is. When you get further into the program and you start learning about mechanical ventilation, where you actually have somebody on a ventilator, you're breathing for them, we actually can dial in a very specific PEEP for these patients. And some of the things that we take into account, or just to kind of help you guys have like a visual in your mind, is if you can imagine somebody who's laying flat in bed, who's unconscious, and then also happens to have, let's say, a large abdomen or belly. So there's a lot of reasons this can happen. Weight can be a factor, muscle tone can be a factor, pregnancy can be a factor. But let's say that they're laying flat and there's a lot of weight pushing down on their abdomen. When you think about the way that that's going to impact their lungs' ability to inflate, it becomes kind of a barrier to their ability to ventilate well. So if the diaphragm is contracting and moving down into your abdomen, and that's how you kind of increase your thoracic cavity, and your ribs are moving up and out, if you have that weight from the abdomen kind of blocking those muscle movements, then you're going to start to see areas of lung collapse. So one of the things that we can do is we can turn up a patient's PEEP, or positive end expiratory pressure, and essentially keep their lungs more inflated than normal after they exhale, so that hopefully we can prevent lung collapse. And this is obviously a little further than what you guys need to know at this point, but I sometimes find it helpful to connect concepts a little bit earlier so you can kind of see the path it's going to take. Your patient case scenarios and your questions on your exams are not obviously going to be this detailed, but this is kind of where this is going to be going as you move into the treatment of patients and the treatment of diseases. You could also try to think of a patient who had a very low compliance lung. And having a low compliance lung would mean that that lung is not stretching or inflating the way that it should, okay? A lot of things can cause compliance to be lower. Having fluid in your lungs, having a fibrotic lung, or having like scar tissue in your lungs. There's a lot of different things that can make your lung less compliant or less stretchy. So if you have that, have an issue with low compliance, if you can keep a higher level of PEEP in those types of lungs, it will keep them stented open and make it easier to keep inflating them on inhalation without as much pressure. Another example would be a patient who has like increased elastance or increased recoil. Again, if you have this positive end expiratory pressure that's stenting open the lungs after you exhale, it's going to be easier for the ventilator. It's going to be easier to get a breath back in on the next inhalation, because you're not having to overcome as much of that surface tension or as much of that recoil, because it's been stented open with that PEEP or with that volume of gas. So if you're looking at that same pressure time curve, you can see again, this is your PIP, this is that big breath in. Right at the top, you kind of have that breath hold and you hit that plateau pressure, and then here's where you'd be exhaling. And without PEEP, you would exhale all the way down to this baseline, but because you have this PEEP, or this volume of gas that stays in your lungs all the time that's exerting a pressure, you don't drop down to baseline. And you can think of PEEP as the small amount of air that's in a balloon that makes it much, much easier for you to inflate that balloon. Absolutely same concept with the lungs. This is just another visual to kind of show you if this balloon collapses all the way down in the same way that your alveoli could collapse all the way down. When you have lung collapse, it's called atelectasis, right? So if this collapses all the way down, if you have an atelectatic lung, it's going to be significantly harder for that to open back up. You're going to require much, much more pressure. We also talked about this when we talked about Laplace's law. So if you have, let's say, this alveoli over here and this alveoli over here, and if you can try to imagine like a bronchus here that's veered off, because this alveoli that's collapsed is going to require so much more pressure to inflate, that air is going to want to go to this partially inflated alveoli, because that's going to take much less pressure to open it up, because it's already slightly stented open, okay? So if you have this kind of partially open alveoli, it's going to be much, much easier to reinflate it, because you're going to have less surface tension and less elastance. This guy over here is going to be very hard to reinflate. It's going to require a lot of pressure. So this is an example of PEEP stenting that open and really kind of helping to aid with that reinflation. This is just another pressure time curve. You guys do not need to memorize the different pressure time curves, but what you are going to have to do is understand kind of like the PIP is here, the plat is here, the PEEP is here. If I had you label it, I would put in like the actual line for this graph. You just would have to label it. So this is just another example, but it shows like the beginning of inspiration. It's building, building, building. This is when your lung is inflated. That's your PIP. Change in pressure down here is plat, because this is where you're doing a breath hold right before exhalation, and then down to the PEEP, okay? So this has a mathematical application. So this C dyne just means dynamic compliance. The C stat is just static compliance. So the math that we're going to do for this is you're going to be given a tidal volume in milliliters, and then you're going to divide it by a pressure. So for the dynamic compliance, you're going to use that peak inspiratory pressure, because that's the one that's with the air movement. So you're going to do peak inspiratory pressure minus your PEEP. And that's because you're looking at the change in pressure from up here to all the way down here with the PEEP. The C static is going to be essentially the same equation. You're going to start with your tidal volume, and that's going to be in milliliters, and then you're going to use your plateau pressure, and you're going to minus your PEEP. So again, change in pressure, your plateau minus your PEEP. And what you end up with is change in volume over change in pressure. And what we're looking at is for every unit of pressure, you should get a certain change in volume. And that's how we're going to calculate compliance. And it takes a little while to wrap your brain around all the definitions, and sometimes I'm not very math-minded, so sometimes it takes me just a minute to kind of absorb all of that. But all you're looking at here is, again, the stretch of the lung. So if you think about the fact that for every unit of pressure that you're applying to the lungs, you should get a certain volume of gas. And we're going to be looking at what is normal versus what is not. So this is kind of just a slide that has a review of all the terms that I could think of that might be helpful. So tidal volume, with its two abbreviations that we talked about, and it's the amount of air that moves in and out of the lungs with each respiratory cycle. The average is around 500 mils in an average healthy adult. Compliance is abbreviated CL. Again, that's just the stretch of the lungs. If you see a triangle, it's just a delta sign, and it just means change in. Change in volume, change in pressure, difference, kind of same thing. CWP is centimeters of water pressure, and that is just the unit we're going to be using for all of our pressure numbers or pressure calculations. V equals volume, P equals pressure, ml is milliliters, and then this is just kind of a synopsis of what we talked about with peak inspiratory pressure, plateau pressure, and PEEP. So for dynamic compliance, it's the measure of the pressure upon inhalation. It's overcoming your frictional and elastic forces. Change in volume over change in pressure. So you'll have a tidal volume over peak pressure minus PEEP. Over here, we're talking about your static compliance, which is a measure of the pressure while the lungs are stationary during an inhaled breath hold, right before exhalation. This one is only going to be overcoming the elastic forces. Okay, still the same concept of change in volume over change in pressure. You're just changing kind of what pressures you're looking at. So for this one, you're going to use your plateau pressure minus your PEEP. The units for this equation are going to be milliliters over centimeters of water pressure. So this is where your milliliters are in your tidal volume, and this is where your centimeters of water pressure are down here, because these are your pressure units. The normal for a healthy lung is 60 to 100 milliliters per centimeter of water pressure. And what that's saying is for every unit of pressure, you should get somewhere between 60 to 100 milliliters of gas. So that would be a normal stretch or a normal compliance. So this is kind of a way to think about it. You guys haven't learned yet about fibrotic lungs or emphysema. I mean, on the surface, and you guys probably talked about it in survey. So I'm just going to really quickly define when patients have severe emphysema, there's a lot of tissue breakdown, and what can happen is they get an overly stretchy lung. It breaks down so many of those alveolar sacs that it literally creates a stretched out lung. On the opposite end of that, you have something called fibrosis. And fibrosis, in its simplest definition, is a scarring of the lung. It basically takes that thin, very delicate tissue, and it makes it very thick, and it makes it harder for it to move. Okay? So what this is showing, it's a little bit different than the curves that we've been looking at. This is a volume pressure curve, and you can see this because you have volume here on the y-axis, and pressure here on the x-axis. And what this is showing you is for a normal lung with 10 centimeters of water pressure, if you kind of follow it up here, you get, 2.5 liters of gas in that lung. So that's what they are saying is a normal volume of gas for 10 centimeters of water pressure. If you come down here to a fibrotic lung, and this would be a less compliant or less stretchy lung, essentially, you can see that 10 centimeters of water pressure gets you 1.5 liters of gas or volume of gas in that lung. So significantly less than a normal lung, because this lung isn't stretching, this lung isn't opening. So this would be considered a less compliant lung. If you look at the lung with emphysema, and again, you go to the 10 centimeters of water pressure and you follow it up, you're getting almost 4 liters of gas for that lung per 10 centimeters of water pressure. So this is going to be considered a normal compliance. This is going to be less compliant, and this is going to be more compliant, okay, in a bad sense. Because when you think about the fact that if you get a super stretched out lung, you can get air in very, very easily, right? This shows you with very little pressure, you're getting 4 liters of gas in. So you can get air in very, very easily. But you have 2 parts of your ventilatory cycle. You also have to get air back out. So when you think about the fact that the lung is supposed to snap kind of back into its original position, and that's how you're getting gas back out, this lung can stretch really easily. It cannot recoil back down. It doesn't have the elastance. So lots of stretch, not enough elastance. So these patients actually have what's known as air trapping. They have a hard time exhaling all their air out. So this is just kind of like the practical application of the math that we're learning. There is a lot of different components that you are going to learn about that affect the lung and change the compliance of the lung. And it's something we're really interested in understanding as respiratory therapists, because it has a significant impact on how a patient can ventilate. So this is a couple x-rays that I just kind of threw in here because I'm a visual person. Like, this works for me a little bit better than a graph. So if you have increased compliance or stretch in an emphysema patient, you're going to have a decreased elastance or recoil because they're opposites. So stretch and recoil are opposite, compliance and elastance are opposite. So this is a normal chest x-ray. You can kind of follow the anatomy that we've learned here. These are the clavicles, right? This is the trachea. You have the apex of the lung up here, come down to the bases. This is the costophrenic angle. This shows the domes of that diaphragm here. You have the 2 halves, and that's your primary inspiratory muscle. So that's a normal x-ray. This is somebody who has probably late-stage COPD, but specifically emphysema for this patient. And you can notice that the lungs are much more black, which means that there's much more air. They're much more translucent than they should be. But the big thing that I want to draw your attention to is look how much further they come down and how much flatter they are here. That diaphragm is really flattened out. And these lungs are an example of essentially increased compliance or increased stretch. They've gotten so big, their recoil and elastance is gone. So this patient would probably have a lot of air trapping. This is kind of the opposite of what we were talking about with the emphysema. This is going to be somebody who has decreased compliance, okay? So decreased stretch in ARDS, which stands for Acute Respiratory Distress Syndrome. And if you have decreased compliance, you're going to have increased elastance because they are opposites of each other. So this one, I don't know that it's as obvious, but this they're calling their normal chest x-ray here. Again, you can kind of follow down the anatomy. Over here, you can see how much higher the lung is on this side, and it's a little bit higher on this one. It's not as drastic an example as the previous one, but this lung is essentially collapsing and kind of shrinking down. And that's because as areas of the lungs collapse, they're harder and harder to reinflate, and they will kind of shrink on you because when you think about it, portions of it are no longer being opened up with each breath in. So they're going to kind of continue this cycle of collapse. And again, we're very concerned about this when we're treating these patients because we care about their breathing. That is our job. So there's a lot of ways that we can treat it. There's a lot of ways that we can do interventions to help these patients that you guys are going to continue to learn about. So very similar graph as the other one, just a little bit, I guess, more detailed here. So you can kind of see, again, the lung volume versus the pressure. This is going to be increased compliance, normal compliance, decreased compliance. Just kind of want to continue to show the same example because I feel like this compliance elastance concept has been difficult in previous years. I really, really want to drive it home so that you guys can kind of lock it in. Okay, so showing again the math of this, or how we would apply this in a mathematical way. I gave some numbers here so that you could do kind of a practice example here. And I just use 0 for PEEP just for ease of numbers on this. I realize that generally speaking, this is not going to be 0. It's just for the example math for that, so don't read too much into it. But I just am trying to show you how this would be applied. And then I will post some practice problems for this as well. And then you also have the homework that kind of takes you through these different calculations. If you have any issues, definitely reach out via email. Otherwise, we'll talk about it in our review sessions as well. This is just another kind of practice one for you. In class, we'll give you the answer for this, but I'm using the tidal volume of 500. I want you to calculate the static compliance and the dynamic compliance. We'll talk about it on, I can't think of what date we're going over this PowerPoint, but I will post a key for this slide and we will talk about it in class. But in the meantime, if you're working ahead, go ahead and try the math and see if you're kind of understanding how you would do that. Same thing with your pressure time curve here. You have a peak pressure, plateau pressure, down to your PEEP. These are your lecture questions. When you're defining the PIP and you're defining the PLAT and you're defining the PEEP, make sure you write out what they stand for. So PIP is peak inspiratory pressure, and then really try to define it in your own words. I think that some of these concepts in the past have been really fuzzy, and if you guys really lock into them now and you get a good understanding, it makes everything so much easier later on. When you're learning about disease and you're coming back to these concepts, they're that much easier. When you guys get into life support and you start learning about artificial ventilation and how we essentially breathe for people when they're not spontaneously breathing, and you've really kind of latched onto these concepts, it's so much easier. And at the end, I feel like everything kind of compounds and you have a lot of tough material all building up on you. So I really encourage you guys, if you have questions, ask them early, and don't just learn these for my unit exams. Really learn them and really understand them, because I just feel like it makes everything so much more easy as you move through and it gets more complicated. So that is it for this one.